When reducing a Smith or volar button fracture, the reduction maneuver should include A. Supination only, B. Extension only, C. Extension and supination, D. Extension and pronation, E. Flexion and supination. And the answer is C. Extension and supination. Now let's get to know a bit regarding the Smith or volar button fracture. Smith fracture is a volar angulation of the distal fragment of an extra-articular fracture of the distal radius. It is actually the reverse of a Colles fracture with or without a volar displacement. This type of fracture is caused by falling backwards and planting the outstretched hand behind the body cause a forced pronation type injury. These are less common. This picture illustrates the difference in the mechanism of injury and bony injury between A. Colles fracture and B. Smith fracture. For Button's fracture, it is an intra-articular fracture of the distal radius with associated dislocation of the radiocarpal joint. Button fracture can be described as volar, it is more common, or dorsal, it is less common, depending on whether the volar or dorsal rim of the radius is involved. For Smith fracture reduction, the treatment of a non-displaced or stable Smith fracture is by close reduction and splint or cast. The reduction is done by reversing fracture deformity with longitudinal traction and applying a long arm cast with the forearm in supination and wrist in neutral or extension. Okay, you guys, bye. Which of the following is false regarding a cartilage-forming tumor? A. Osteoistoma, B. Exostosis, C. Enchondroma, D. Chondroblastoma, E. Chondrosarcoma. And the answer is A. Osteoistoma. Now let's get to know a bit regarding a cartilage-forming tumor. As an introduction, cartilage-forming tumors are a group that are the most common primary bone tumors. This is largely due to the common occurrence of asymptomatic benign lesions such as osteochondroma and enchondroma. The common features of these tumors is the presence of chondrocytic cells and the formation of cartilaginous tumor matrix. Some of these tumors are true neoplasms, while others are hematomas or developmental abnormalities. The morphologic heterogeneity of these tumors may be explained by a common multipotent mesenchymal cells differentiating along the lines of fetal adult cartilage maturation. For osteochondroma, it is a benign outgrowth of bone and cartilage and is one of the most common bone tumors. Often referred to as exostosis, there is a debate whether they constitute a true neoplasm or bony outgrowth of the metaphyseal plate. They may develop following a surgery or fracture. Osteochondroma are the most common radiation-induced benign tumors. loss of genetic material from the long arm of chromosome 8 has been detected in some of these tumors, as well as mutation in exostocin genes, EXT. For enchondroma, it is a benign tumor of cartilage involving the medullary cavity, enchondroma, or the surface periosteal chondroma of bone. It is thought to be arise from displaced embryonic growth plate cartilage. Recently, mutation is isocitrate dehydrogenase IDH1 and 2 have been reported. It is a relatively common tumor, often discovered incidentally. It occurs especially in young to middle-aged adults. This X-ray illustrates an enchondroma that occur in the medullary cavity of the left fifth metacarpal bone region. For chondroblastoma, it is a benign tumor of bone involving mainly the epiphysis. It is relatively rare, accounting for approximately 1% of bone tumors. It can affect a wide age range, but it is most common in the second decade, males more than females. The long bones are most commonly affected, followed by foot, the calcaneus, and talus. Localized pain or swelling are often the presenting symptom. This X-ray illustrates a chondroblastoma, whereby it manifests as a round or oval radiolucent area in the epiphysis. For chondromyxoid fibroma, it is a very rare, benign chondromyxoid neoplasm, often misdiagnosed as chondrosarcoma. It affects patients of all ages, with a peak incidence in the second and third decades. Pain is the most common presenting symptom. The long bones are commonly affected, followed by the iliac wings, the ribs, and fib. That means the metatarsal bone. The typical radiologic appearance is that of an eccentric, elongated, radiolucent defect in the metaphysis or diaphysis of long bones. The margins are scalloped and well demarcated. As illustrated, X-ray of the left knee joint shows an elongated lesion that affects the metaphysis or diaphysis region, and it is well demarcated. Regarding a chest wall hematoma or chondromesenchymal hematoma, this is not a true neoplasm but rather a congenital malformation. This condition typically affects the infants and presents as a large chest wall mass, which can cause breathing problems and the chest wall deformity. Radiologically, there is a large expansile mass that destroys and deforms the adjacent ribs. However, it is well demarcated and does not involve the lung parenchyma. In this chest X-ray, the left lung shows a large chest wall mass with deformed adjacent ribs. Last on the cartilaginous tumor that we are discussing are chondrosarcoma. Conventional chondrosarcoma is a malignant neoplasm composed of hyaline cartilage. It is the second most common malignant primary bone tumor. The tumor may arise from de novo, primary, or secondary to other tumors. It is a disease of middle age to old adults, although individuals of any age can be affected. And finally, regarding our earlier answer, osteoid it is not a cartilage-forming tumor. Osteostomas are small, benign, osteogenic bone lesions most commonly found in the proximal femur. Patient typically presents between the age of 5 to 25 years old with regional pain that is worse at night and improve with NSAIDs, non-steroidal anti-inflammatory drugs. The diagnosis is made radiographically by a characteristic lesion that is less than 1.5 cm in diameter with a sclerotic margin and radiolucent nidus. Okay, that's all for today. Bye. The following procedures create a tamponade in hypovolemic pelvic injury except A. Angiographic embolization. B. C-clamp. C. External fixation. D. Pelvic sheath. E. Pelvic binder. And the answer is A. Angiographic embolization. Now let's get to know a bit about each procedure. In patients who are both hemodynamically and mechanically unstable, and in whom the major bleeding is thought to be related to the pelvic fractures, external stabilization of the pelvis becomes the first priority. Because of the main sources of bleeding are most frequently the presacral venous plexus, around 80%, and fractured bony surfaces, external stabilization decreases the hemorrhage by reducing the volume of the pelvic basin and approximating the fracture ends. Example of an external stabilization include 1. Pneumatic anti-shock garments, PASG, or medical anti-shock trousers, MAST. 2. Pelvic binders or pelvic sheaths. 3. Anterior external fixator, AEF. 4. C-clamp. Regarding angiographic embolization, it is used to control a post-traumatic intra- and retroperitoneal bleeding. Vermanos et al. Reported on 100 patients evaluated by angiography for bleeding from major pelvic fracture or solid visceral organ injuries. In total, 80% patients were embolized due to active contrast extravasation or indirect signs of vascular injury or hemodynamic instability. Angiographic embolization was safe and effective in 95% of these patients. In a study by Agolini et al. Of 806 patients admitted with pelvic fracture, 35 underwent pelvic angiography and 15 patients, only 1.9% required embolization. Bleeding was successfully stopped in all of the embolized patients. However, there are still no studies that report the true frequency of arterial bleeding in unstable pelvic fracture. Angiographic embolization is time-consuming, and using this technique hinders the simultaneous treatment of other injuries. The answer to our question, angiographic embolization is rarely indicated in patients with unstable pelvic ring fracture and hemodynamic instability. Angiography can be justified only in patients who are hemodynamically stable with arterial bleeding detected by computed tomography or with ongoing hemorrhage after C-clamp or application and pelvic packing. Okay, thank you.